starting that. Okay, I'll turn it over to our colleagues.
And I have the good fortune of going first. So my name is Sarah Mills, as introduced, the CEO of Healthcare Access Now. And today, along with my colleagues Rita and Jenelle, we're going to talk to you about community health workers and the hubs. So next slide. Please. Oh, and this just says who we are, in case anyone forgets.
All right.
Next slide. So we wanted to begin this conversation with talking to you about the history of hubs, and the history of hubs really begins with community health workers. Community health workers in the United States is actually not a new idea. In the mid-60s, they were used as some of the public health in some public health work around the country. And then where our story really begins with the hubs began in the 1990s when Drs. Mark and Sarah Redding developed their pathway model. It took them many years of hard work to refine this model, and along the way, different groups began to be interested. They did publications related to this work, and in that process, they refined the model to include the hub as part of it. So it began really with the structure of the work for the community health workers, the pathways that we use, but then it began to include the hub itself. And there were 3 hubs that formed in the state of Ohio prior to the certification process. There was a hub in Toledo, the Northwest Ohio Hospital Council, I think, is the last word on that. And you'll see them in a later slide. Healthcare Access Now. Oh, sorry.
Sorry.
Yeah.
Letting into the
and then also the hub that the Reddings actually began in Mansfield, Ohio, which we refer to as CHAP, which is a community health access point, I believe. So CHAP, HCAN, and the Toledo hub were formed in doing the work. And then in 2016, the Reddings created the certification process and also a body to hold that process, which is the Pathways Community Hub Institute. So you'll see us refer to them later on in the slides. At the beginning of the pandemic, the hubs in Ohio, by then, many more of us had come along. So Rita and Jenelle's hubs had been formed, and we had begun to meet informally, and then realized that we really needed to come together more formally. So in 2001, we actually formed an official network, and we have been meeting as a group, not quite as long as your group, but since the beginning of the pandemic, every week, to help each other define best practices and just support each other throughout the process of running hubs. And in 2003, with NextGen, we have begun to pilot some programs around value-based payment and other kinds of payment structures to continue to move this work forward. And I think we want to note here that the Commission on Minority Health has been a longstanding supporter of the hub model. They have provided significant funding to help launch many of the hubs in the state. In fact, most of the hubs in the state at this point. And they continue to be a great support. And with the Ohio biennial budget, there has been an increase in the funding from when it began to now that really has allowed for the expansion of the hubs across the state. Next slide. So we would be remiss if we did not mention Senate Bill 332. This piece of legislation really created the mandate for the plans to begin to reimburse hubs. Now, some already were prior to this, but this created the requirement for reimbursement for community health worker work through the pathway hubs. And they have been both Senators Tavares and Jones have been big supporters of this work for a very long time. Next slide. So today, this is the network. Today, virtually every community in the state of Ohio has a hub supporting it. There are different capacity levels across the state. As hubs are growing or coming on, there are a lot of local kinds of impacts to each hub, and we're all slightly different organizations. So for instance, Healthcare Access Now is a standalone 501c3. Other hubs are connected to health departments or community action agencies or healthcare. I'm sorry, I'm blanking on the way to refer to it, but organizations that support health systems, that's what I'm trying to say. So there's a lot of variation in the structure, and the reason for that is each hub is really formed based on the needs in the community and the stakeholders in the community that are coming together to form the hub. Next slide. So we do all of this work with the pathway model. And we weren't going to spend a whole lot of time here because you can go online, go to the PCHI-Hub website and read a lot more about it. But what the PCHI model does for us is it creates a framework for quality improvement, for reimbursement, and it's standardized across all the hubs that are using this model. So we can report out on our work in the same way. There's also a demonstrated return on investment. And later in this, we talk a little bit more about that, but the Medicaid managed care plans have recognized the value of this work and is why they're contracting with us. And really, ultimately, the model allows the community health workers' value to be leveraged and used to support communities who are under-resourced or at risk for poor health outcomes. And ultimately, it improves health and reduces cost and promotes equity, which is really what our work is all about. Next slide. So just a quick snippet again, these are the 20 evidence-based pathways that are standardized. This provides a framework for every community health worker working in every hub across the state to identify barriers and then work to help a client overcome them, and then document in the same way, the same data points, so that we can have a standardized approach. Next slide. And for more information, I think we did, as I said, you want to go to their website at pchi-hub.org. There are some model updates coming. There are now going to be 21 pathways, and we're in the process of adding those improvements and that are coming for the new model. At this point, the Ohio hubs have not fully transitioned. We are in the process of transitioning to these model updates, but fundamentally the work is the same. You're identifying barriers and working to overcome them. But for more information, you can visit their website. And the next slide, I believe, is me handing off to Rita. Yes. So Rita is going to talk about pathway hubs in practice. Thank you.
Thank you, Sarah. Thanks for that overview. So I run the Better Health Pathways Hub in Northeast Ohio. It is part of Better Health Partnership, which is the Regional Health Improvement Collaborative here in Northeast Ohio. It's been around since 2007. But we are one of the newer hubs. We didn't start ours until 2020. And so we're thankful to those pioneers like Sarah and HCAN who went first and really worked through an awful lot of the heavy lifting, if you will, and getting to a standardized model before we came into the mix. Next slide. So this slide is just meant to give you a visual of how the hub model actually works. We thought we'd put together just a few slides to show you everyday transactions and how that occurs. Essentially, what you're looking at here is in the middle of the diagram is the hub itself. So think of the hub as the infrastructure or the machine that makes all of this work and all of this possible, this care coordination at a community level possible. So referrals can come into the hub from community. So might have food banks could send people, churches, any kind of agencies out there in the community can make a referral to the hub. These are people who they feel could benefit from aligning themselves with a community health worker to meet their health and social needs. Referrals might come to us from health system partners that we have, from managed care organizations, their members, they might be referring to the hub, or of course, community health workers themselves could refer to the hub. When those come in, the hub team triages those referrals. And then going to the left-hand side, we'll send that referral to a care coordination agency. The hubs contract with agencies in the community. And these agencies hire community health workers, so they actually employ them, not the hub itself. And those agencies might range from a very small nonprofit community-based organization that maybe the community health workers work in homeless shelters, for example. But they also could be, the agency can also be a large health system itself. Like in our area, it would happen to be as large as the Cleveland Clinic. So that gives you an idea of the variation here in agencies that the hub can contract with. And so when that referral comes over, the agency will then assign a community health worker who begins to work with the client, identify their needs, enrolls them in the hub. And when they identify those needs, they open what those pathways are that Sarah showed you. Once they believe that they have completed their pathways, the hub team then does all the quality assurance, does the documentation review, make sure everything looks appropriate. And then once that's all looks good, we proceed to create an invoice and send that to the Medicaid managed care organization for which the client is a member of. So we have contracts, for example, right now with 7 managed care organizations in Ohio. And so we could be invoicing any one of those to get those payments aligned with the pathways that have been closed. So sometimes that managed care organization will also make referrals to the hub for their members. And it just makes for a nice synergistic relationship there where it's benefiting people in the community and benefiting their members as well. We do a lot of professional development with community health workers that Jenelle's going to talk about later. We do a fair amount of evaluation and reporting, tons of that that's required, and do some ROI, as Sarah mentioned as well. And we all have community advisory boards and work on some advocacy opportunities. Okay, next slide. So just wanted to give you a snapshot of like some of the risk factors we might see in some of the clients that are being served. And again, every hub is different. Every hub services different types of populations, so these could absolutely change depending on the area that they're serving. In our particular case, these are the clients that were enrolled from January to December of 2022. And you can see that some of our top risk factors here, unemployment being the largest one at 84%, 74% at underlying chronic diseases, non-pregnancy. Income here is less than $5,000 a year. So you can only imagine the needs of some of these folks. And certainly mental health diagnosis plays a big role as well in a lot of the clients that we serve. Next slide. So this is an example of the types of pathways that Sarah had showed you on her 20 evidence-based pathways slide. For example, again, these are some of the numbers and types of pathways that were opened and closed in 2022 within our hub. And you can pretty much see here the top ones, at least the most frequently used pathways here are social service referrals, no surprise about that. And that could include things like utilities or transportation or food needs or clothing needs, things of that nature. Education pathways, so our community health workers often provide education to clients that align well with the types of needs that they have or things that they see when they're working with clients. So if it's a new mom, let's say, it might be about breastfeeding education. There might be, if the mom is pregnant, they might be doing some lead exposure education to be watching out for lead in the homes. COVID-19 is another type of education pathway, and so on. Medical referrals is another top pathway. Often these folks need connected to medical homes, to other types of medical appointments. And it just to make a note, these pathways are not paid for or even considered successfully closed just by making a referral. The client actually has to go and to that appointment has to be kept. And that is why this is an outcome-based model. And I think aligns very well with how payers might want to engage with the hub. And in our case, we had 80% of our pathways were successfully closed during the time period, meaning that the client did not disengage, and that would be a reason for closing, but rather the needs were met. And then the next slide just lets you know that client feedback is also a big part of the hub operation. We think that feedback's really important to us. It helps make us better. And we have just gotten started with this, at least the one here in Northeast Ohio. So in 2022, we had about 30 responses from clients. And the nice thing is we had about 81% say of the clients said that they would refer their community health worker to a friend. And we thought that's a pretty good number. And then 79% said that they got connected to resources for their needs. And 74% said that the resources they were connected to actually met their needs. And we have started to do some interesting comparison work with these large social referral platforms that are very popular now here in Northeast Ohio. We have all of our health systems are using Unite Us as a big social referral platform. And so we're starting to do some comparison data to say how are the needs of those clients being met versus those of going through the hub, the Pathways Hub. Early data would suggest there's a pretty significant variance in what we're seeing by way of those client satisfaction results and needs being met, with the hub at this time looking to be more favorable. But more to follow on all that. It's early. Okay, and I believe that would be, I'm going to turn it over to Jenelle at this time.
Thanks, Rita. Hi, everyone. Jenelle Hoseus. I am the CEO for the Central Ohio Pathways Hub. We are the hub in Franklin County, the contiguous, and then Ross and Marion County area. And we're housed out of a regional health improvement collaborative, or a RIC, that is called Health Impact Ohio. So lots going on within the work that we do within the local community. And today I'm going to be speaking a bit to some of the community partnerships and events that we have, really the background, education, training, workforce development pieces for CHWs, talking a bit about the special populations that we serve, and then also dive just a little bit into the surface area of the Hub Association that was created in Ohio within the last few years. So with that, we'll go to the next slide, please. So one of the things that we have really tried to amplify and support in Ohio is emphasizing the importance of CHWs and the uniqueness that they are. So they are not quite social service, they're not quite medical, they're somewhere in between. And what's really important is that they are a trusted resource within their local community. So really focusing on the idea that they are community health workers rather than community health workers. And that part to us is really important. So Sarah Mills actually did a ton of due diligence in getting this all put together, but in Ohio, we actually have an official State Community Health Worker Day, because we want to take the time to give them that light, you know, and to celebrate them and the work that they do and all that they're contributing back to the community. So this year we'll be celebrating again on June 6th, and we're going to try to do, bless you, I think, more and more community events so that we can continue to celebrate them in all of our local areas. Next slide, please. So this is actually a CHW statewide assessment that was done in 2018 in collaboration with the Ohio Department of Health and Ohio Colleges of Medicine Government Resource Center. And this just really gets the perspective of what the responsibilities are of a CHW within Ohio. I can tell you firsthand, because I contribute to some of our CHW certification course curriculum, as well as our monthly meetings with our CHWs, there is never a time where our community health workers are not seeking additional information. They are always at the top of their game when it comes to providing information, being the ones to understand how to use that information and how to deliver the information to the clients that they're serving. So here you can see that obviously the number one thing is connecting individuals to community resources, but really close behind that is educating and motivating, right? We can't encourage folks to participate in getting you know, those closed loop referrals accomplished and connecting them to care and services if we aren't thinking about how to approach them where they are. And that's exactly what CHWs do. And so this is just a great example as to how receptive the CHWs are to learning and getting more information about all of the nooks and crannies of what would be helpful for their clients and the folks that they know in the community. And then really thinking about how they translate that into something that's meaningful for those individuals. Next slide, please. So in Ohio, there was CHW certification, as you can see here, back in 2003. There was some language that helped amplify some of the standards and expectations from the Ohio Board of Nursing, which is where the CHW certification lives, in Senate Bill 332. But really thinking through the notion that their certification process is both didactic as well as hands-on. We're trying to work with them to make sure that they're getting solid curriculum in a classroom setting, but then also getting to see it put into application. We in Central Ohio have a CHW certification program. I know Sarah has one, and Rita works very intimately with the certification program up in the Cleveland area. And all of us have had the hands-on experience of getting to better understand the importance of these core competencies and seeing how all of this information might be utilized. Because of the interest in both community health workers and the Pathways Hub model from Senate Bill 332, which was the really focused on infant mortality and maternal and child health, there does tend to be a focus on that from a larger Ohio dynamic when it comes to the expectations of what a CHW knows and does. I will tell you in Central Ohio, I'll just speak for myself, and I know that the other two ladies on the line can speak to this as well. We focus on serving the community at large. And so for us, our certification program is truly meant to be teaching everything from prenatal care to end of life planning and everything in between. We also do significant work when it comes to understanding exactly what health disparities are, because that is primarily where our CHWs have to spend a lot of their time. So all of the core competencies that you see there, we've really taken some time to augment, and we're doing quality improvement after each of our cohorts to make sure that we are really thinking through how we expound upon all of those areas to make sure that regardless of the person that our CHWs come across or work with, that they're able to approach them with empathy and some baseline of understanding as to their needs and where they can go for resources. Next slide, please. So one of the questions that we get sometimes is, why certify? It's not necessarily a requirement across the state of Ohio, but it is for us as hubs. The Pathways Community Hub Institute, which is our certification body, requires that each of us as hubs either can confirm that each of our CHWs is already certified or that they're working towards certification, which is part of the reason why we've all done a lot of work, whether it's in grant writing or curriculum development or really opening up our programming to make sure that anybody in Ohio is going to be able to access it so that they can participate in this model. But more importantly, I think for me personally, is the notion that when our CHWs come out of this certification process, they are much more knowledgeable for the clients that they serve, but they're really excited about the work that they're going to be able to accomplish. And so it's a huge opportunity for them as individuals. They've had continued education. They're better able to serve the community at large. And having some letters behind your name, it always gives a little bit more credibility. So there's a lot that's been gained from this experience. And these are the top 3 reasons that have been called out specifically for why folks certify. This is great. Stay here. So then barriers to certification. The programs can be tedious and long. In Central Ohio, we had an organization that was great at getting CHW certified, but part of the process was that it required either them to do the classroom experience during work hours, which is difficult, especially if you're already employed, or it was needs-based. And so if you're already employed and you can't meet that criterion, then it becomes a little bit more difficult for you to find an appropriate setting. So there are also pieces, whether it's from payer contracts or otherwise, including OBN's perspective around background checks. We have advocated for a handful of our CHWs that do have a record of some kind. Obviously, we really stick to nonviolent offenses, things in that space, but a lot of our CHWs have lived experiences that make them that much better at what they do. And they're able to overcome those life experiences and really push themselves into the next space that they want to find themselves in. And we find that to be an incredible asset in this work. So we have worked really hard to better understand some of the nuance there. Next slide, please. So this is just for the Central Ohio Pathways Hub certification course, but just wanted to give you all a better feel for the diversity that we serve within this CHW course. So you can see the breakdown of ethnic and racial backgrounds, the age demographics, gender identification, which, I mean, honestly, that cohort was such a beautiful experience to have individuals interact with someone who identified as they, them, and really have that individual speak to some of the disparities that the LGBTQIA+ populations have experienced. So even within the cohorts, we're having so much robust conversation that's eye-opening and empathetic and forward-leaning, that it's been really beautiful to watch such a diverse group of individuals get to learn from one another, learn from us as instructors, and we learn a lot from them. So it's been really great experience so far. Next slide, please. And this is a great example. This is a HRSA grant that Rita's team up at Better Health Partnership is leading out work on, where we're really trying to expand the workforce and training programs and increase readiness within the CHW communities. We really want to make sure that workforce development and professionalism are part of the ongoing conversation with the CHWs, so that they're both able to meet the community need as well as the professional needs. And so it's all tied into the work that we're all trying to contribute to. So next slide, please. So this is a slide from PCHI, just to give a better feel from their perspective about the different medically related as well as socially related areas that the hub model can be helpful with. And I'm actually going to have you go to the next slide if you don't mind. Because part of what we've tried to do, and again, I'm speaking for myself, and I know Rita and Sarah have plenty of examples of these of their own, but this is just an example. This data is slightly dated. It's from fall of 2022. But in looking at what CHWs are able to accomplish, we want to make sure that we're really focusing on the fact that maternal and child health is far and away one of our largest initiatives, but it is far and away not the only one. So when you think about, for example, we participate in the Ohio Commission on Minority Health Infant Mortality Grant. We had 92% of our babies born. Actually, last year in total, it was 94% of our healthy babies were born at healthy birth weight. We examined some of our COVID-19 related efforts and really focused on the fact that over half of the folks that we were providing information and services to related to COVID-19 were Black or African American. We also participate in a theft diversion program with our city prosecutor's office, where individuals where it was their 2nd through 10th offense of petty theft at a big box store worked with the CHW for 6 months on goals that were agreed upon between the prosecutor's office and the CHW after a comprehensive risk assessment. And for the first 2 years of that program, we had 95% of the individuals not reoffend. So we're really thinking about how do we solve for social determinants of health that change a trajectory, that change the ability for somebody to really stay on a path that they're choosing to participate in. And so we just wanted to give some of those examples as to how CHWs can impact in ways that are outside the normal course of practice. Next slide. So this is a study that we wanted to just share with you all in terms of impact. This is a study that was done with the Northwest Ohio Pathways Hub and Centene, or Buckeye as we call them in Ohio. And it really focuses again on that maternal and child health piece, but they were able to see that high-risk moms without the hub intervention were 1.55 times more likely to deliver a baby needing special care or NICU stay compared to those with a hub intervention. And this report is really impactful. I would really encourage anyone who's interested in the hub efforts to take a look at this, because there is a really high ROI on that report. Next slide. Next slide again. Thank you. So this is just a quick overview about the network and what we've been doing in Ohio. So as soon as the pandemic started, we started meeting about once a week, if not more frequently, because quite frankly, as the medical community was completely strapped, CHWs were literally and figuratively going in to support individuals, dropping off cribs to mom's doorsteps, being the literal lifeline for people who were on lockdown for 2 weeks. Anything that you could think of, our CHWs were trying to do it. And it became a great way for us as a group of hubs to get on the same page, do quality improvement, learn from one another, have open dialogue. And it started our association. And so this gives an example of all of the work that was done in the COVID-19 space. We've also paired together on a CDC COVID Resilient Response in Communities grant through the Ohio Department of Health, which has been fantastic to educate our CHWs about not just COVID vaccines, but behavioral economics and how to approach different population types and reporting guidelines and all of these other different facets of importance during the pandemic. And so I just wanted to make sure we touch on this. That CCR grant, I think, has been one of the first ways where we've all really come together to be lockstep in what we're reporting. Our CHWs having every other week sessions where over 150 of them every single session are learning about this information. And it's been a really beautiful experience. The one thing that isn't called out on, I don't think any of these slides that I just at least want to mention, and Rita alluded to it earlier. When we think about care coordination, specifically with our CHWs, one of the spaces that I think we're all moving towards is interoperability. And it's becoming even more evident that that's going to be a critical component of the work. In Ohio, when we carved behavioral health into our Medicaid managed care plans, the director at the time used to say, now we're going to be able to see the person from head to toe. And that's wonderful from a medical perspective and absolutely necessary. But now with interoperability, we're going to be able to see the person in totality, because providers' offices are not inclined to ask questions for which they don't have a great resolution for, right? They don't have the bandwidth, maybe the front office staff, et cetera. But now as we're getting into IT platforms that allow for the community relationships, the CHW's work, the community organizations to show their referral processes, to show the social determinants of health and drivers of health that an individual is facing and overcoming, that's going to give a lens into the person in totality. And I think that that's going to be a really powerful, powerful opportunity for us as a state, a country, as a people, to make sure that the person is getting all that they need to have that quality of life and better health outcome. Next slide. That's it. Lisa, you're on mute.
Sorry, that was because I was coughing before, so I'm all done with that. So thank you very much. First of all, it's a wonderful presentation, and it just is inspiring to see the work that has been underway for so long and then really accelerated in a time of great need over the last few years. I think, as you've seen, there's been quite a bit of chat, questions and answers, but I wanted to open it up to follow up on some of those questions if they were thoroughly or not thoroughly addressed.
Well, I see the last couple there, and I started to type and I realized it would be better to say it out loud.
Okay.
And Rita and Jenelle can help me answer with some of these. On average, what percentage of the funding comes from the fee-for-service transactions with payers versus other indirect services? I will say that is a hub by hub kind of calculation. And it really depends on the populations we're serving. So if I have a fully funded and the contracts with each Medicaid plan, because each one's a little bit different. So sorry to be so vague. I would say it's no more than 50% at this point for most hubs if they are serving non-funded clients. And Jenelle and Rita, feel free to disagree, because I think it is going to be different in each space.
It's going to be very different dependent on the organization and the populations that they serve. And Deidre, I see a lot of questions around Z codes or billing codes. We're reimbursed out of the administrative cap rate for the plans. And so while there are billing codes associated with the work that we do, it's not Z codes, it's not anything that's standardized in terms of standard medical reimbursement from the plans. They're all based off of agreed upon contractual arrangements that are, again, out of the administrative cap rate.
If you had a structure where a CHW is placed in a hospital or physician partner, would then the provider be able to build that Z code for the team-based care of the CHW?
The work is done separately from what they would bill through their EHR. So there has to be a distinct line between the work that's being accomplished via the hub versus anything else in the hospital setting. In a really high level and watered down version, I try to think of it as the CHW doing the connection to the care and service versus the hospital participating in the care and service itself. So I don't know if that helps kind of draw a line in the sand there.
It does, but I also just thinking from a hospital's perspective. So if there's a CHW in a hospital and they're part of the hub, they're not then they're not an employee, nor are they billing under the hospital. Is that correct?
They are an employee of the hospital, and there are plenty of CHWs who do additional work for hospitals outside of the hub space.
Yeah,
But anything that they're doing that is hub specific or under the guise of the PCHI model has to be done within our particular IT platforms. They're not done in the EHR or anywhere else. And they have to be differentiated from any other service codes of work that they might be participating
got
in.
it. So they need to be agile enough to know that this patient is under this population, and I should document in this system.
Yeah.
And then I'm over here with a Medicare Advantage or an uninsured patient, and I should document over here.
We often encourage them to use a screening tool of some sort so they can kind of triage and understand exactly which way the client's supposed to go.
That's very helpful. That makes complete sense.
And the other question in that, I want to make sure we address is, we do not necessarily receive any baseline funding. We have various grants. Some have been for a very long time, but they're not guaranteed. I'm thinking the Commission on Minority Health has provided funding to support hubs. I think we're in our 8th year, but it isn't any kind of baseline funding that we can necessarily count on forever.
Mhm.
We'd like to, but we can't.
Yes. We'd love
Nor
to.
would it cover the costs of everything that's going on. So
That's
So we
right.
have a lot of braided funding.
we're very grateful for it, but it wouldn't cover
Yeah.
everything.
But I would like to add one thing, and you touched on it, Sarah, in your opening slide, where we are in 2023 and where we're going. There's been a lot of recent conversation about really bringing the Pathways Hub into more value-based contracts. And I do think this is going to create some opportunities for some additional revenue for our agencies. If we can look at true quality incentives and targets they might hit and have that ability to receive more revenue, and similarly for the hub itself. So we're really looking hard at a lot of those opportunities and where we can bring the hub into either already existing provider contracts where the hub can now become part of that value-based arrangement. And there also could be some just specifically for the hub itself with some quality incentives. And I think that's a year out maybe until we start seeing that happen, maybe sooner. We also have some pilots going with Medicare, or at least just getting started with one of our managed care organizations getting into the Medicare space. So it's beginning to pilot that work as well.
I see a hand up, Lisa.
Yeah, great to see everybody, and great to hear the terrific work you guys are doing. Thank you so much. I was particularly curious about the issue, interesting, you just talked about the issue of some CHWs working some part-time or on the side for hospitals, but here in Maine, where I'm from, it's been a real challenge to sort of protect the CHW identity as a community-based resource and function. And particularly while we, the old law of unintended consequences, we've tried to build in funding for CHWs into our main Medicaid primary care, our comprehensive primary care program, by funding practices to either contract with or employ. The health care providers are pretty quickly saying, we'll just do that. We'll just hire them. That way they can document in our EMR and it'll be a lot easier for everybody to, share information and all that. So we're really kind of concerned about co-opting of the model by the healthcare, medical side of things. And what it sounds like that has not really happened there. And I'm curious how you've done that, or was it an issue, and how did you end up where you are?
Yeah, so I'll take a first swing at this one. I'd say we are literally every day fighting against that because not to say that CHWs don't serve a purpose in those roles, or that they shouldn't play a role within those facilities and organizations, but we know that the community level relationships are what makes that position what it is and makes those job opportunities what they are. One of the things that we're trying to really focus in on to the interoperability piece is we just contracted with Unite Us to become our new IT vendor for hub purposes. And one of the reasons that that's critical for us is they are working to also incorporate into the state health information exchange. And so as we think about the interoperability and ease of use, we're going to have the ability eventually to have our data and the data from our health system partners, et cetera, be in a singular location so that all of that bidirectional information flow means that we can keep the CHW in that community focused lens, but still get the data components that kind of resonate with the medical community. So I think for me, that's one of the things that I'm really hopeful. I haven't hung my hat completely on it yet, right? But like, I'm very hopeful that as we move to a space of that being, you know, a functional response, that perhaps we'll be able to better mitigate those concerns on the front end rather than have to be reactionary to some of the seeming threats of not having CHWs within the actual community in which they live. Rita, Sarah, I don't know if anyone else has additional thoughts.
I was just going to add, so I was one of those people in the hospital setting responsible for value-based care that created my own CHWs. I didn't call them CHWs. I wasn't even fully aware of the hub model, but they're driven by the responsibility of those contracts and being able to make sure that they recognize that many of their medical framework that they have doesn't really meet all the needs and can't really deliver against those contracts. So I am hopeful that this blended understanding of all driven towards better outcomes for patients brings us to a greater understanding and collaboration for both. Because I think if it's one or the other all the time, it's never really going to work. And we're always going to be distracted without just focusing on what's the best thing for the patient. So I am hopeful, particularly I know Rita, you've done a ton of work with the HRSA grant that is allowing more hospitals to, that's why I'm interested in the placement, you know, the payers, the managed care organizations, or the in-between kind of organizations that support dual eligibles and the hospitals, all of this connectivity about best practices for patients is what I'm excited about.
Yeah, thanks.
Not necessarily
Yeah,
purity of anybody's power or control
Yeah,
we've got to let go of that to be able to move forward.
I think you said that very well. Thank you for saying that. I think that we have to get more comfortable with the coexistence of how
Yeah.
the roles are being dispersed, and recognizing the value, no matter sort of what setting they're in, preserving absolutely the community piece, what makes them very unique and special, but also recognizing that, you know, the health systems need these folks in their offices as well to help with these patients and identify them early and get their needs met. So with the work we're doing with this big HRSA grant, interestingly, we have probably, 6 or 7 health systems in the advisory board that has been formed at the Northeast Ohio regional level for this. This is one of the topics, so I'm not surprised you brought it up, Lisa. This is it, you know. And so we have our work cut out for us to get everybody comfortable with this transition almost, right? Because it started like Sarah described it. Here's how it started, and this is why it was so successful. We want to preserve that. We want to build on that. But we also know that this is a growing profession and it's needed roles. So, and Lisa, by the way, it's very nice to see you again. You probably, I don't know if you remember, I came to see
Of course
you
I do.
back in the AF4Q days. So great to see
A
you.
lot of AF4Q buddies here still. So yes, absolutely
Yeah.
great to see you, Rita.
Yes.
And I see one other question around the summary of where folks are placed, where CHWs are placed. There is nothing that really exists exactly. However, locally within Cincinnati, I am trying to gather that information. But it is really difficult. And part of the challenge with this is that, number one, people call community health workers other things, or they refer to someone as a community health worker, and that's not actually the job they're doing. And so I think part of the role of the hub in each of our communities is really helping everybody get clear on what is a community health worker. And it's okay to have those other roles. Like, I don't want anybody to misunderstand. I think there are lots of roles that are necessary in a team approach, right? But if a person is not doing community health worker work, they should not be referred to that way. If we can get folks to do that, then we'll have a better chance of measuring. The Ohio Board of Nursing, you can go online and see how many people have an active certification in any county. And you can see their names. And in fact, for the Cincinnati folks, one of our community health workers within our hub has license number 2. in the
Really?
state of Ohio, yes. Which is kind of fun. Yeah, so the answer to your question is no, there is not that I'm aware of.
I will say each of the hubs have, well, most of us, I think, have our CCAs all listed, so you can see the organizations that we work with, that type of thing. But yeah, there's not a succinct way to better understand because the titles are far different depending on where you are. But yeah, there's some great CHWs out there, so very lucky to have as many as we do in the state of Ohio.
Well, thank you so much. This has been, first of all, a great presentation, great discussion. Obviously, this is something that is very important to people, and this is a group of people who are engaged in different aspects around healthcare and the various systems, whether it's health systems, insurance, state Medicaid agencies. We've got sort of the gambit here. So really happy to have this, and thank you very much for your incredible work and for sharing it with us. I really appreciate it.
Thank you all so much for having us. It was great.
Having us. Thanks for having us.
Right.
Absolutely.
Take care.
Bye.
Yeah, bye-bye. So as a quick reminder, just for those of you that the Innovation Center at CMS is working on new models. Everybody knows that it's under wraps. It's everything sort of black box. And but my understanding, and this is really from press at this point, is that there will be models announced in this calendar year. So there's progress being made. I hear rumors of things sort of entering the Byzantine channels that are the approval processes, and certainly hopeful that a lot of the work that we have all done together over the last decade or so in terms of primary care innovation models and multi-payer work is going to be reflected in these new models. But I have very little information to share at this point, and I'm looking forward to hearing more from our colleagues in Baltimore in hopefully the next half year. And then another quick reminder for those of you that are involved in primary care first, there is a national meeting, which is once again virtual this year, May 16th and 17th. If you have not yet signed up to attend, you can attend part or all of it. Certainly, they would love to have you if you're involved in primary care first. So with that, we will be adjourning this meeting and reconvening in another 3 months. We do not have an agenda set for that date yet. I'm very open to suggestions. Please email me with ideas and we'll set something up. I will not be here at that time. I'm going to be taking a leave of absence for 3 months for fun, like my friend Lisa Letourneau. It's kind of a grown-up gap period. Just taking some time away from work as we start to wind down our careers for my husband and me. So these meetings will go on. We'll have a wonderful facilitator, I'm sure. We're working on that right now. So stay tuned. And thanks everybody for being part of this.
Thank you.
Bye.